Hi everybody, we're going to start today with a new topic called fluid electrolyte balance. This comes from a chapter that covers two big topics, fluid electrolyte balance and acid-base balance. You'll notice that acid-base balance is covered in lab. Let me start you out on your course pack on page 118. And we're going to talk about fluid compartments in the body. We know that babies have more water in their body than adults. But everybody's got water stored mostly inside cells, and that's what we call an intracellular fluid compartment. That comprises about 2/3 or 66% of the body's fluids. The other 1/3 of the body's fluids are stored in the extracellular environment. That is the space outside of our cells. So two main places that we see extracellular fluids are in the interstitial spaces. We call that fluid interstitial fluid, or IF for short. And we know that blood plasma also accounts for a good portion of our extracellular fluid. So just as a way of review, ICF is the fluid inside of a cell. The fluid between a cell is technically an interstitial fluid. It's a type of extracellular fluid. Here's another cell with ICF. And then if we have a capillary running through here, there's blood plasma in that capillary. That is a type of ECF. Okay, so the number one place for fluids to be stored is inside those cells as intracellular fluid. We know that fluid moves between these compartments by osmosis, so fluid can move between the blood plasma and the interstitial space. Fluids can also move between the interstitial space and the cells. So osmosis drives the movement of fluids between these compartments. At the very bottom of page 118, let's talk about water balance and some factors that come from your life. Age is certainly a factor on how much water you have in your body. The younger you are, the more water you have in your body. As we age, we tend to literally prune up. We become raisins as we get older. We have less water in our bodies by the time we reach our elderly years, 70s and 80s. So water content decreases with age. At the very bottom of page 118, number 2, gender also plays a role in water balance. Adult males have more water than females. And the reason for this actually is numbers 3 and 4, how much body fat a person has and how much muscle they have. The percent of water in your body will decrease with increases in percent body fat. So the more fat you have in your body, the less water you actually can store. Water, of course, is not found in fat at all. Muscle, however, causes more water to be had in the body. So males that are lean with more muscle tissue than fat are going to have more water in their body than a female. All right, so that should cover page 118 for us. Let's take a look over at page 119. And here's a number to know. The typical amount of fluid exchanged per day is around 2.5 liters. That means you're taking in around 2.5 liters of fluid per day, and you're losing about 2.5 liters as well. If you stop and think about this, you're probably not drinking 2.5 liters. You do get fluids in your beverages. You also get fluids in the foods that you eat, and a very small portion is what we call metabolic water. So let's talk about that fluid intake. What you bring in per day is mostly in your food and drink. So 90% of the water that you bring into your body is found in the food and the drink that you take in daily. Only about 10% of the water that you get is coming from the process of metabolism. Since we want to preserve the amount of water in our bodies and not lose that water, we have a very strong mechanism here that helps to maintain water balance in the body. It's called the thirst mechanism. And so literally it drives us to drink. And the writing reason behind it is having an increased osmotic pressure. So if you have a salty meal or increased salt concentration in the blood for whatever reason, that will drive us to have a sense or an urge that we need to drink fluids. You also know this because if you have decreased saliva or if your saliva feels rubbery, then you want something to drink because you'll say, I have a dry mouth. So that's part of it. We drink when we have an increased salt concentration in our bloodstream. In other words, an increased BOP will make us thirsty. Likewise, the thirst mechanism also involves antidiuretic hormone. Where's antidiuretic hormone made? It's made in the hypothalamus. No mistake, that is the part of the brain that controls drinking and eating, hunger and thirst. So when you are thirsty, hypothalamus also promotes the release of ADH from the posterior pituitary. ADH travels to the DCT of the kidney and promotes water retention there by inserting aquaporin, which are water channels. So what we see with the thirst mechanism is a two-pronged approach. We not only have the urge to drink, that's part of it, but ADH is also making us retain water in the kidneys. Now, when ADH is in control of you, when you're thirsty, you're going to have decreased urine output. That means you're going to pee less. So what color will your urine be? It'll be dark yellow, it'll be concentrated, and there'll be a small amount of it. So on your worksheet, there's a question about middle of the page 119. It says, when do you stop drinking according to this thirst mechanism? Well, what would have to happen to your BOP to make you stop drinking? It would have to be back down into a normal range. And of course, you stop drinking when you feel like your thirst has been quenched. Okay, so when your BOP returns to normal and when you have quenched your thirst, you stop drinking. That's important, right? Because otherwise you would drink until you bloated and cells would rupture. Let's talk about fluid output. You will want to note that the kidneys are the route through which we lose the most water per day. That's around 1.5 liters of fluid that are lost through the kidneys and through urine. You'll also want to note that we lose the least amount of fluids through our GI tract per day. That's only around 100 milliliters of fluid. That's not a whole lot. So interesting to note here that urine is the route through which we lose the most fluids, and feces are the route through which we lose the least. Let's talk about sensible versus insensible fluid loss. Insensible fluid loss is ones that you don't feel, you don't sense it, you're not aware of it. So if you are sweating on a really dry day, you may not feel any wetness on your skin, and so we say that is an insensible fluid loss. Now, if you go outside on a really humid day, you may have wet, sweaty armpits, you may feel sweat beating up on your face and your skin. That is called sensible fluid loss. So some of the fluid loss we experience per day is insensible, not aware of it, versus sensible, you are aware of it. And so we do experience insensible and sensible fluid loss from the skin, and mostly what we experience from the lungs is an insensible fluid loss. Although if you go outside on a cold winter morning and breathe out, you see your exhaled breath, that is a sensible loss of fluid. You're aware of losing that fluid because you can see that fog on a cold winter morning. So let's talk about how we regulate and some things that influence fluid output. We know that antidiuretic hormone and ADH both increase blood pressure. They do it through different routes. Antidiuretic hormone is released by your posterior pituitary in response to salty blood. ADH goes to the DCT and the collecting ducts of the kidney and inserts aquaporins or water channels. That will cause us to retain more water, and by doing that, we're going to decrease the urine output. So if ADH is in control of you, you're going to produce very small amounts of dark yellow urine. Aldosterone is kind of a tag team player with ADH. They work together to increase blood pressure. Aldosterone doesn't retain water directly. It does so indirectly by retaining sodium in the kidney. So if sodium is retained, then water follows. This hormone will also decrease urine output. So if aldosterone is in control, you will also have dark yellow, small amounts of concentrated urine produced. The last three on this list, hyperventilation, vomiting and diarrhea, fever and burns, all three of these will increase fluid loss or fluid output. So each one of these will remove more fluids from the body. All right, so that takes us down to the bottom of page 119. Let me take you over to page 120, and let me talk to you about the columns that are listed here. We're getting ready to talk about common electrolytes. You actually know most of what's on this page. For starters, electrolytes are chemicals in the bloodstream that can conduct an electrical impulse. They're in the blood, they're in your intracellular fluids, they're in your interstitial fluids. So you probably learned a lot about sodium, potassium, and calcium back in Bio 210. Now, let's categorize these by anions and cations and where they're located. You'll notice the common cations in the interstitial fluids, now those are the fluids between your cells and tissues, are sodium and calcium. The common intracellular cations are potassium and magnesium. I've got a trick to remember those. I know that potassium is actually spelled with a P, okay, and of course magnesium. And I remember that PM is the beginning of the word plasma membrane. So these two are found inside the plasma membrane of a cell. In other words, they're found in the cytoplasm or cytosol of a cell. So you already know a lot about this. If you think back to talking about muscle contraction, you might recall that muscles had a lot of potassium on the inside of the cell, and sodium was waiting patiently on the outside of that cell when that cell was at resting state. So this is nothing new here. We already know where sodium and potassium are located. Let's talk about anions with a negative charge. We know that chlorine is found in interstitial fluid. Sodium and chlorine, they go together, right? That's table salt, so it makes sense that they're found in the same space. Bicarbonate ions help to maintain blood pH. They're a very important buffer, and we'll talk a little bit more about them on the bottom of this page. We know that carbon dioxide is transported as the bicarbonate ion, and the kidneys can also create more bicarbonate if needed to maintain blood pH. So chlorine and bicarbonate are found in the interstitial fluid. Finally, phosphates are found inside cells. And I keep in mind again, P reminds me that that is an intracellular type of ion. So if you take a look at page 120, that covers the left column. I want to point out to you that calcium is the most common ion in the body. Okay, let's just put a star around that one. Most common ion in the whole body. The most common cation in the extracellular fluid is in fact sodium. And the most common anion in the extracellular fluid is chlorine. All right, so that takes care of that first column. The second column talks about the hormones that control each of these. That should be no surprise to us. We have covered aldosterone. We do know the connection between aldosterone, sodium, and potassium levels already. In our last chapter, we learned about chlorine and bicarbonate also playing a role in being controlled by aldosterone. You probably also remember from earlier in this course, endocrine system, that calcium is controlled by PTH or parathyroid hormone. That in fact is the main controller, and that's the reason there is an asterisk beside PTH. Calcitonin and calcitriol also influence calcium levels. Under the function column, the most of the information here is something you've seen before. You'll just want to read through that column, noting the new term at the bottom of the column there, buffers. And then excess conditions and deficiency conditions have boldface terms. For each of those blocks, you'll want to learn the boldface term and the deficiency term. A helpful hint here, anytime you see the suffix emia, E-M-I-A, what does that mean? That's a condition of the blood. We already know that hyper means an excess condition of the blood, and hypo means a deficiency condition of the blood. So now the trick is, what does that root mean? So hypernatremia, for instance, is excess sodium in the blood. Just be cautioned about calcemia and kalemia. They're spelled similarly, but calcemia is specific to a calcium problem, where kalemia is specific to a potassium issue. We'll wrap up that page by talking about the two problems at the bottom, respiratory acidosis, respiratory alkalosis, and metabolic acidosis, metabolic alkalosis. We'll wrap that up on the bottom there in just a few minutes. So let's talk about sodium. Now we're going to work across that row. We know already it's the most abundant cation in the extracellular fluid. Just keep in mind the most abundant ion in general is calcium. We've already learned a lot about sodium in a previous course. We know it's important for muscle and nerve impulse transmission. We also know it's in the extracellular fluid, and it's a big contributor to blood osmotic pressure. Hypernatremia is a new term for us. What does that term mean? That term means excess sodium in the bloodstream. So high aldosterone means that we may retain more sodium in the kidneys. A high salt diet can also cause hypernatremia, just temporarily until your kidneys work it out. And then dehydration can also cause hypernatremia. So taking a look here, anytime you have too much sodium and not enough water to balance it, then we end up with a case of hypernatremia. I mentioned here that this is typically temporary with a high salt diet, but if you maintain a high salt diet day to day, then your kidneys can never catch up and excrete enough salt to bring your blood pressure back to normal. Hyponatremia, here's a new term for us, means what? That's low blood sodium levels. That can be caused by low aldosterone, which means you won't retain as much sodium. Water intoxication is the opposite. Water intoxication means you've drunk too much water in a short period of time. Remember glomerular filtration rate? Your GFR was only about 120 milliliters per minute. So if you're drinking more than a half a cup of fluid per 30 minutes, your kidneys say, hey, I operate at one speed, that's my GFR, and I can't keep up. So unfortunately, your blood plasma, your interstitial space, and eventually your cells become flooded and bloated with water. And so water intoxication can imbalance the amount of sodium that you've got in your bloodstream and your interstitial fluids. Calcium is the most abundant ion in the body. Just want to make that point one more time. Okay, we already know it's an important component of bones and teeth. We've talked about its role in blood clotting. You probably remember that it played a role in muscle contraction and nerve impulse transmission. Calcium is regulated primarily by parathyroid hormone. Calcitonin also plays a role in lowering blood calcium, depositing that excess to the bones. And you may recall that calcitriol is vitamin D3, and that also helps to regulate calcium and phosphorus metabolism in the bones. Two new terms for us, hypercalcemia and hypocalcemia. Hypercalcemia can be caused by excess parathyroid hormone. Too much calcium in the bloodstream is a bad thing because, look here, it can affect your heart, and that's going to be a problem for people who have parathyroid tumors or hyperparathyroidism. Excess calcium can also inhibit muscles and neurons, whereas the lack of calcium can cause your fingers and toes to tingle. You ever notice if you hyperventilate or get really excited, you have tingly fingers and toes? That's because of a shift in calcium when you hyperventilate. So hypocalcemia is lack of calcium in the bloodstream, and that can be caused by too little PTH or too little parathyroid hormone. People who have a thyroid gland surgically removed, they have to be really careful not to take the parathyroid glands as well. If those parathyroids are accidentally removed, then we do see problems with heart arrhythms, with tetany, which is muscle contractions, fingers and toes tingling. Let's talk about potassium for just a moment. We know this one is an abundant cation in the intracellular fluid. That's the fluid inside of our cells. We already know it's important for nerves and muscles to remain at rest and metabolic functioning. It also helps to maintain osmotic pressure inside of a cell. Let's talk about potassium problems. Hyperkalemia and hypokalemia both have that K in there. That's a great reminder that we're dealing with the potassium issue. Let's talk about hyperkalemia first. This is a case of excess potassium. Low levels of aldosterone are called hypoaldosteronism, and we can also call that Addison's disease. In this case, a person may accumulate excess potassium in the bloodstream. This can be problematic because it leads to muscle weakness and cardiac arrhythmias. We also know that hypokalemia can be caused by excess aldosterone or Cushing's syndrome. In this case, we may see muscle weakness and cramps or constipation. Lasix and diuretics can also cause potassium imbalances as well. Chlorine is the most abundant anion in the extracellular fluid. It is found as a component of hydrochloric acid in the stomach, and it helps to regulate osmotic pressure between the compartments of our bodies. So because it's in the extracellular fluid, it balances the ions inside the cell. So we've got to have a balance there to help maintain pressures, osmotic pressures between these areas. Hypochloremia is more of a problem than hyper because vomiting removes the chlorine from the bloodstream. Of course, vomiting can also cause problems with alkalosis, something we'll get into when we talk about acid-base balance in just a few minutes. So bicarbonate at the very bottom of your page is an important buffer system. In fact, it is the most important buffer system in the bloodstream. We know that carbon dioxide can be transported as bicarbonate ion, and the kidneys can also filter and reabsorb that bicarbonate back into the blood. If necessary, your kidneys can also manufacture bicarbonate ions to help maintain blood pH. Now, in your bloodstream, bicarbonate acts as a base, which means it has an alkaline nature to it. So when you increase the amount of bicarbonate in your bloodstream, you are giving it more base. You're making that pH more alkaline. So just keep in mind that the respiratory system can manage bicarbonate by getting rid of it through exhaling out CO2. The kidneys, however, can also manage bicarbonate by helping to either reabsorb more of it, which will make your blood more alkaline, or your kidneys can reabsorb less of it, which will make your bloodstream more acidic. So just something to think about there. Bicarbonate can be managed both by your respiratory system and by your kidneys. And of course, kidneys can filter and reabsorb it if needed, and the lungs can remove it as carbon dioxide. So on the bottom of your page down there, bicarbonate can help manage respiratory problems. It can also help manage metabolic problems, something you'll cover in more detail in lab.